Welcome everybody to this event, which is part of Chalmers AI Talks, which is a flagship event of the Chalmers AI Research Center or Chair. And it's a great a pleasure and honor for us to have today and Professor Madhav Marathe. Madhav is Distinguished Professor in Biocomplexity in the Department of Computer Science and Engineering at the University of Virginia. He's also the director of the Network System Science and Advanced Computing Division at the Biocomplexity Institute and Initiative at the University of Virginia. Madhav has a very long track record and experience in transdisciplinary science, starting from his time at the Los Alamos National Laboratories a long time ago, and over a period of 20 years, he and his team have supported federal and state authorities in a number of um, efforts and initiatives to tackle pandemics, in particular in the H1N1 pandemic, the Ebola outbreak, and most recently COVID-19. And so his research combines, it ranges over a large spectrum from very foundational computer science to these transdisciplinary science applications. It's a great illustration of how these things can interact with each other. And finally, last and most important for us here, I should say that Madhav has a very special relationship to Chalmers. He has been an affiliated faculty in the Division of Data Science and AI at Chalmers for a number of years. And he's been a very regular visitor over a very long period of time. Unfortunately, curtailed a bit because of COVID, but let's hope that we manage to resume that in the near future. So over to you, Madhav.
Thank you very much, Devdutt. It's a pleasure and honor to speak at this meeting. As Devdutt said, I have a very long-standing relationship with Chalmers University. Devdutt and his colleagues have been very kind to invite me and my colleague Chris Barrett there for a number of years. I think probably 13 to 14 years now that we've been working together. I want to thank Devdutt, but also his colleagues Sonia Ye and Francis for interacting with us. And in the end, I will talk about a possible work that we can all do together in the context of Sweden. So with that, let me begin. As you all know, work like this doesn't get done in isolation. I want to thank a number of different grants and granting agencies for supporting the work. I've listed them there. Importantly, I also want to thank all the members of the team that have so kindly worked on this work for now over 1 year that we've been working on COVID response. This is not work that I have done alone by any means. There's a team of about 80 of us who work on this. I have some folks shown here in the picture. Also our collaborators beyond our institute that work with us closely at places like Princeton, Stanford, Virginia Tech, and other places. For this work that I'm going to talk today, I really want to acknowledge and call out Jiangsu Chen, who has played a very central role in the construction of this particular piece of work. So thank you, Chen, for being part of this. Today's talk is to highlight the role of AI and computing in pandemic response and predictions. This is part of the AI lecture series, as I understand, and I'll try to meld together these two really important topical areas in the world, AI and computing on one side and pandemic response on the other side. And hopefully by the end of the talk, I'll be able to convince you that computing and AI can play a significant role in trying to support policy making and policy assessment during a pandemic, such as the COVID pandemic. It also serves as an excellent example for AI for social good. And hopefully in the end, you will see that we've come a long way that we can really talk about doing real-time pandemic science now. So with that, let me begin. First of all, I want to highlight the fact that the modeling work that we have done and decision informatics work we've done is to try and develop a core capability in real-time computational epidemiology. And we really want to go beyond the concept of predictions in real time. Of course, predictions are important, forecasting is important, but I think models can be used for many, many other things, and they are actually equally or perhaps sometimes more important than just doing forecasting. From synthesis of different data sets into a consistent and meaningful representation, to providing a range of interpretations to incoming measurements, to evaluating range of possible actions and behaviors, counterfactuals, to monitor the intervention response and coordinate understanding among diverse stakeholders. These are some of the many things that models can be used for. And hopefully, as I go through the talk, I'll be able to highlight many of these topical areas that tools from computing and AI can be used to support them. So, a traditional way to study epidemiology, and this goes back close to 120, 130 years, and even before that, if you look at Bernoulli's work, is the concept of compartmental mass action models. Very popular, very powerful, elegant and simple in many ways. And what it says is the way to study epidemic transmission is through a set of differential equations. Here I've shown you a very simple set of three differential equations. You can have more, you can have stochastic versions, and so on and so forth. But in this simplified model, which is really very powerful already, you have three compartments, S, I, and R, susceptible, infected, and recovered, respectively. And you write a set of rate equations which tell you the rate of change of concentration of these three compartments, S, I, and R. Again, as I said, a very popular model started to be used early 1900s and has provided significant support to policy making with this. And I think it's really continues to be an important modeling framework. Today, I will talk about a slightly different approach to this problem, which is concept of networked epidemiology. And the basic hypothesis we have here is that if you want to understand epidemic spread in a realistic system, then we want to represent the underlying social contact network between individuals, along with the behavioral adaptation that individuals might go through. And we feel that that would effectively give a set of better insights into the contagion dynamics and also lead to better response strategies. Now, this doesn't mean that one has to choose one versus the other. At different stages of the pandemic, depending on the data, different models are useful. So what I'm trying to argue here is this is another class of models that is perhaps powerful and useful under many circumstances. And you'll see one of them in today's talk. So in very simple terms, and this is the only slide on network epidemiology that one needs to follow, and then we can go through the program, is you have a network. And in this cartoon, I have 7 nodes. The node colored red is the initial node that is infected, denoted by V naught. Edges have labels, and think of these labels as transmission probabilities on the edges. The way the dynamics evolve is infected node tries to infect its neighbors, and we'll use the independent cascade model where V naught tries to independently infect V1, V2, and V3 with probability 1/2. If the event is successful, then one of those nodes will be infected, and then the system proceeds. What you get at the end of this procedure is a large Markov chain. And the hard problem here is that while the representation is given in the simplistic form, all the analysis has to do with the analysis of the underlying Markov chain. And I think Professor Ravi and Professor Dick Stearns are online, along with Professor Rosenkrantz, and I've been working with them for a long time now on trying to understand the theoretical foundations of studying these Markov chains. So, of course, this model is very nice and clean, but there are real challenges in the real world, such as who gives you the network in the first place. I was trained as a theoretician where I could start my paper by saying I was given a network and then I want to study some properties of the network. What I found over the last 20 years is making this network is probably one of the hardest problems here. The analysis is then done relatively easily, at least if you have enough computing power. How do you analyze the dynamics? How do you design interventions? How can you forecast these dynamics? All these questions become much more challenging and messy in the real world. So let me outline a program that we have developed now over, I would say, good 20, 21 years, at least for epidemics, but goes back to 1995 to a project that Chris Barrett led on transportation modeling, wherein we tried and studied this from first principles. And here is how we start doing it. It has got 3 very simple steps, at least in terms of explanation. In step 1, we create a digital twin of a city or a country that we want to study. What's a digital twin? It's a digital representation of the underlying network and the underlying population of a city, along with the infrastructure, in a manner that preserves the privacy and of individuals and anonymity, but statistically represents a underlying city that you want to study. What it gives you is a social coordinate system, which is spatially explicit. So starting 1994, as of today, we have now synthesized such a digital twin for the entire US, about 300 million nodes, about 15 billion edges, and these edges are time varying. We usually have done this for a normative day, where people travel, carry on their day-to-day activities, have a household. Households have the right structure based on census. Household in California is quite different than a household in Virginia, potentially. The kinds of distances people travel is different and is based on travel diaries and surveys. Now with digital devices, you can actually do a better job in trying to understand how people move around. So all this information is captured in building a digital twin of a particular region that we are interested in. And this will play an important role in the study that I'm going to describe later. In second step, we build a model of how disease evolves within an individual and how the disease transmits between individuals. These are within host and across host disease transmission models. Here's a movie that we had developed based on a hypothetical study of adenovirus spreading out in US, starting in New Mexico. The key aspect is if you want to build these simulations, it requires fair amount of computing resource. And the first question you might ask is, do you even need simulations to study these dynamics? So in a paper that we have written with Ravi, Dan, and Dick, we show that indeed, from a computing standpoint, these problems are computationally intractable. It turns out they are number peach hard for reachability of such stochastic systems. And so simulations are indeed the only real way to try and address the search of this Markov chain. In the third step, we use simulations then to create workflows. And these workflows try and address or solve questions that we're given, from analysis of the simulation to forecasting, to studying efficacy of different intervention strategies, to studying inverse problems, assessing risks, and doing economic impact analysis. All these are workflows which use simulation as essentially a subroutine to try and study the problem at hand. So let me tell you what we've been doing over the last year or so. I would say now more than a year. We started this work somewhat early, and that will give you a context and a basis to think that this work that I've described is not just a theoretical sort of piece of work, but is being put into practice and operationalized in a significant manner. So we started work understanding this problem early December when we got a first sense that this might turn out to be a different outbreak than we had seen in other cases. And by March, we were deeply involved. We constituted a team of about 80 scientists, staff members, and students at UVA and collaborating institutions. And since then, have been deeply involved in supporting various federal, state, and local agencies. So we support various federal agencies listed here, including the CDC, DHHS, DOD. We support our state, the Commonwealth of Virginia, and various departments within the state. And then we support local agencies and university systems, closed university systems here. And the way it works is we provide briefings, data, and analytical results to them every week. We have about 6 to 7 presentations that we do. Those presentations and data lead to new questions based on how the disease is progressing, which is then used to drive the next set of models that we would consider. So just as one example, if you go to the website, which is maintained by the Virginia Department of Health, vdh.virginia.gov, you will see the kinds of outputs that the Department of Health produces based on our model. I've just shown you 2 of these charts, but they're based on very detailed analysis that we do. And I want to again call out the team that does this day in, day out now over the last 52 plus weeks. Brian and Srini have played a very important role in making sure that we do this well. We also build web apps and dashboards that support the agencies. I want to at least just tell you quickly about four dashboards which are in use right now. One is a surveillance dashboard. This was built almost at the same time as the Johns Hopkins dashboard. It's been quite popular as well, not as popular as theirs, but still quite useful. And you can actually visit this dashboard. One of the good things is you can download the data. And this is a global surveillance dashboard. We try to collect data from across all the world and provide this data to folks. Now, over time, other countries and states have started building similar dashboards and have been very useful in their own right. We've also built another dashboard called the Medical Resource Demand Dashboard. Initially, it was meant only for a state, has now been expanded for the whole country. And that tells you the potential resources in terms of medical equipment and hospitals, beds, and such that might be needed in the next few weeks as the disease progresses. So this is based on understanding the ground truth and then projecting the data forward and then pulling in data about available medical resources that often times in US at least is available even if approximately. There's another dashboard that we built that has, I would say, slowed down a little bit with our group at Stanford. Michael Bernstein led this project. It's called the Social Distancing Survey. And there the idea was to try and crowdsource all the different social distancing measures in every county that are in play, because we felt that to run these models accurately, we need to know what policies are in play and for how long. And so this information has been used. This has slowed down. There are other data sets that have come around in the meantime that have done a good job. The last dashboard we just finished is a work that is done jointly with Yuri Leskovic's group at Stanford, and is based on a very nice paper that he and his students, Serena and others, wrote and appeared in Nature, where they build models based on safe graph data and try to understand the role of human mobility and changing the level of closures or openings, if you want to call it, of various sites in order to control the epidemic. So their work was really influential. What we've done working with them very closely is to try and make this so that it works now in close to real time, meaning models produce results every few weeks or so rather than doing a retrospective analysis. And this has actually been a very challenging problem in trying to convert it from a retrospective analysis to going forward. So let me give you two workflow examples, and then I will move to the main part of my talk, which is on vaccine allocation. First is forecasting. I, of course, started out by saying that's not the only thing we do, but it's also one of the things that everybody wants to know, it appears. It turns out forecasting, as you all know, for epidemics or a social system is much harder because of the coevolution problem, where your forecast and the disease can change the behavior, which in turn can change how disease proceeds. So over now 6 to 8 months, we have been providing CDC's COVID forecasting hub maintained by Reich's group at UMass on a forecasting set of results that are based on ensemble model that we produce. Now they have their own ensemble model. So we produce results from various models, some mechanistic, some straight up time series models, some based on neural networks. And then the ensemble of these models is provided as an output to the CDC hub, which then ensembles it further to provide the final results. But this has turned out to be useful. We can actually do something unique that most other groups don't do, which is to provide this result for every county. There are 3,000 counties in the US. Every county has this data produced for every week. And we've been doing this now for a good 7, 8 months. Another workflow that we did, and this is used to illustrate the role of high performance computing, wherein we did analysis of the medical costs that might result due to the pandemic. There are two parts. One is a straight up medical cost, and one are secondary and tertiary effects on the economy. That paper is also in review. This particular figure here shows the work we did for assessing medical cost by studying the simulation over the entire country. It turned out to be a non-trivial effort, had about 10,000 simulation instances. And we tried to argue that we need what's called a HPC grid, which means we have our own HPC platform here, but that in itself was not enough. Pittsburgh Supercomputing gave us access to 20,000 cores every night. And we had to orchestrate the computation between our HPC system, which is about 6,000 cores, and the other 20,000 cores at Pittsburgh every night and pull the data back and forth. Very interesting computer science problem, and it's going to appear in IPDPS this year later on. So let me move to the main topic, vaccine prioritization. I think Sweden is interested in this topic right now. You folks are thinking about this just like every other country. US is already started. I believe Sweden has also already started on this. But hopefully I can tell you something interesting that might at least let you consider alternate strategies. The focus of our study is on vaccine prioritization strategies. Whom should you allocate vaccines? But instead of using just age-based and occupation-based prioritization schemes, we want to use prioritization schemes based on the underlying social contact network. Um, as you might imagine, and as folklore suggests, our results say that if you provide these vaccines to nodes or individuals with high degree, people have called them super spreaders in some cases, then you might end up doing a much better job. And that's a folklore that is based on mathematical results of very structured random graphs and also based on simplified computational experiments. What we are here after is to show that this particular heuristic has a chance of working in realistic but also time varying social contact networks that result when NPIs, the non-pharmaceutical interventions, are being applied continuously, and allocation of vaccines is done as a result of vaccines that are produced by various companies. So this degree-based heuristic and its test on these time-varying networks has not been studied in the past and makes for a very interesting technical question that I'll hopefully talk and explain more in the coming slides. So the overall workflow is as follows. We collect data from various places about disease parameters, and I'll go through all of them. Use data about case surveillance, use data about interventions, non-pharmaceutical ones, use the social contact network for Virginia that we developed and I described early on, and then use epidemic simulations to study various allocation policies and then do analytics on top of it. So the key findings, and then we'll come to the experimental setup and details on these findings. Uh, we set it up when vaccines were just starting to be allocated in our state. And we use our state as a proxy social network. We could do it for other states as well in US. And we think the results will actually work for many other countries as well because the basic structural aspects are not very different. Of course, the efficacy might be a little less or more depending on the specific structure. So for Virginia, we are able to show that in just 2 months, this particular strategy, which is based on assigning vaccines to individuals which have higher degree or higher weighted degree is the amount of time they spend, can result in can result in significantly fewer infections, hospitalizations, and deaths. Between 50,000 and 100,000 fewer infections, about 4,000 fewer hospitalizations, and about 700 to 800 fewer deaths just in the state, and just in 2 months after the vaccines would be given out. They significantly outperform age-based strategies. And what is interesting is perhaps 10 years back or 15 years back, these strategies might have been a theoretical construct. But we think with the advent of digital devices and the contact tracing apps that are already in play, one can actually implement a version of the strategy reasonably quickly and effectively. Important to note that the strategy actually ends up working even when the estimates of degrees and weighted degrees is not quite accurate. And I'll show you plots for it. Three important extensions. One, the strategy continues to work when you relax the non-pharmaceutical interventions. There is a general belief, and it's playing out in US, where social distancing measures are starting to be relaxed as vaccine comes on board. The strategy seems to work very well in those settings. It works when new variants become available and are in play. In US, we already start seeing cases rising for the B117 variant. I do not know the state of affairs in Sweden, but I wouldn't be surprised if that's the case. and other variants as well, the Brazilian variant, the South African variant. In US, there's a Californian variant as well. And importantly for resource poor countries where vaccines are in real short supply, the general numbers we have heard from World Health Organization, other agencies, is that if we continue at the current pace, it might take 2 to 4 years to vaccinate the entire population. And we know that that's not a good idea because people will travel very soon, and as a result, outbreak in one part of the world is going to affect how epidemic progresses in other parts of the world. So here's a setup for the experiments. I will go through this somewhat quickly, but the reason I decided to show the setup is it tells you the complications in building such systems and the need for details to have some sense for why the results might hold. Um, so first, we have used a digital twin for Commonwealth of Virginia, about 8 million nodes. We're done with great care. Every location is represented correctly. The census information is used, travel information is used. We think this is the best representation for our state right now that is available. And we hope to provide this data for others to use as well in coming days. We have a detailed model of disease transmission. I'll show that model in the next slide. We also initialize the system based on cumulative confirmed cases up to December, and these are scaled up to account for a settlement rate and a symptomatic rate. And this is done at a county level, so very detailed seeding of the simulation. Finally, the simulation has 4 different kinds of non-pharmaceutical interventions put in place. One is infectivity reduction. This is by people practicing preventive behavior, mask wearing, hand washing, and other things. Generic social distancing, such as closing down or reducing, shopping, religious activities and such, gym. Virtual learning in many schools in US are closed or have hybrid learning, and voluntary home isolation of symptomatic cases. A person who is symptomatic and chooses to stay at home for some number of days after he or she feels that they are sick. So these are very important part of representing the pandemic and its realistic evolution. And as a result, important that we try to represent this. Now, of course, what specific numbers one has is a challenging question. We have tried to use the best possible guess and estimate on this. And of course, those numbers and changes in them will affect the results, and sensitivity results in paper talk about it in some more detail. So here is a disease transmission model within host, very complicated one, but is again needed to try and represent how progression of disease might happen within an individual, between a person who is susceptible to exposed to pre-symptomatic, later on become symptomatic, might need medical care, might need hospitalization, and either they recover or they die. And then there are two basically branches, one with a person is not vaccinated, another one when the person is vaccinated. This branch becomes even more complicated now that vaccinations have 2 kinds. We have a Johnson and Johnson vaccine, which is 1 dose, and then we have the Pfizer and Moderna vaccine, which are 2 doses and have different efficacies. So these systems become quite hard. They are really modeled as a probabilistic time transition system. The social distancing measures that I talked about are also studied as a scenario. So we talked about 4 different types of social distancing measures, but in the paper, we also consider 3 scenarios. One, where the social distancing is continued at the current levels. And then we consider a slow case in which slowly over a 7-month period, people basically start moving around and decreasing or basically adherence to social distancing norms decreases from certain values to a lower value. And we study a fast relaxation where the same decrease finally happens, but all of it happens in 5 months rather than 7 months. The idea is that we will see this relaxation and we want to see whether vaccinations help or do not help, especially the strategies that we discuss. We also study vaccine schedule. In Virginia, we'll get about 650,000 vaccines per month. This is a 2-dose vaccine, so you get half of it that is going to be used. And we studied, two kinds of schedules. One is a schedule that we were told upfront, and we also studied in the paper a slower schedule because back in December, January, things had slowed down considerably in the US. We will be modifying the paper to study a faster schedule now because it is flipped around where we are starting to get far more vaccines in people's hands now than before. And finally, we study efficacy of the vaccine, as I discussed. The last part is the priority groups, the most important part probably in terms of this particular experiment. We assume vaccines are given only to individuals aged 18 and above. We study 5 different strategies. One is a random allocation. This serves as a base case effectively. One is when you give it to essential workers that are defined based on CDC guidelines. One is to older individuals. And then 2 strategies that are network based. One, where individuals have large number of contacts, meaning degree in the network. And second is when people have large total duration of contacts, which is a weighted degree. Now, to make this realistic, we do not try and give the vaccine to the person with the highest degree and the next highest degree, of course, because these degrees are after an estimate. So we have broken down the individuals into 4 quartiles based on their degree. And so when I say that I would give it to folks in high degree, which have high degree, I simply randomly pick folks from the highest quartile, and I can then go to a lower quartile. The idea is that even that level of assessment of a degree is good enough in terms of the final outcome. And finally, the degree of prioritization. This accounts for how the vaccines are given and how people are identified. The first case is when all the dosage goes to the prioritized group, when 80% of the dose goes to prioritized group and 20% to non-prioritized group in random order, and then 60%. This is basically trying to capture the fact that you might not be able to identify people precisely in our simulations. So this gives you about 12 different scenarios. So let me go forward in the interest of time and show you some results, and becomes interesting here. And then we can take some questions because I would like to leave a lot of time for discussion. So our first result is that in 2 months, in the as-is scenario, which means that there's no change to the non-pharmaceutical interventions, it is as is as of today or as of January, you get significantly fewer cumulative infections compared to age-based strategies, and you get significantly fewer deaths as compared to age-based strategies when using degree-based strategies. Now, in this plot, I've only shown you high degree. Similar results hold for weighted degree. In fact, the results are slightly better in that particular case. Extrapolating this result to the whole US, we think that this might reduce infections by a large number, 3 to 6 million infections, and far fewer hospitalization. Now, interestingly and purely coincidentally, the size of Virginia and in terms of population, and even to some extent the area, is not that far from Sweden. So I just make that point that we have about 8 million individuals here, close enough to the population of Sweden, and a few big cities, and then a lot of rural areas, which is roughly the way Sweden is organized as well. A few big cities and then a lot of rural areas in Sweden too, as I understand. And we can discuss this more later. The strategy of allocating vaccines to folks with high degree, and again, remember, when we say high degree, we don't pick up the first node with highest degree and then the next one. We choose them based on these quartiles. So we've already accounted for a lot of noise in our degree estimation protocol. But it works when you actually assign vaccines either to a normal schedule, which is the one, or a delayed schedule. Now, delayed schedule is not relevant much in today's world in US. It is actually the speeded up one that we would need. And what I've shown you here in the 2 plots is the outcome where, and I should explain what is happening here in this plot. It's a little busy. Let's take the left plot. There are 3 colors, orange, green, and blue. Orange reflects as is scenario in terms of pharmaceutical interventions, which means we continue with the level of social distancing, home isolation, hybrid learning as it stands today. Fast means that you start decreasing the amount of social distancing that people are following, and do this in 5 months. Slow means do this in decrease in 7 months. So those are 3 colors. The y-axis tells you the priorities. So no priority means there are assigned randomly. The age-based priorities are 60%, 80%, and 100%, which means that you give 60% of the vaccines to old folks and then 40% distribute randomly, as we discussed. Similarly, the next set is for essential workers, and then the top part is for the degree-based heuristics. What we show is the number of infections averted or reduced uh, compared to the base case. And you will see in this plot that degree-based heuristics, both in the case of infections as well as on the right in terms of uh, you know when the vaccine is given out slowly, performs significantly better than other strategies that are given out. The strategy actually works when degree is not estimated that accurately. And here, as I said, there are two sources of inaccuracies. One is estimation of the degree, and then capturing every one with that particular degree itself. So this shows you two plots, one on the left and one on the right. The left one is on infection reduction, right is mortality. And we basically are showing you this when even with accuracy of 60%, uh, we can see that the reduction is significant. This is really important to note because we think it's not that straightforward maybe to get the degrees exactly. But even with this kind of misestimation, we think that you will actually get significant savings in terms of infections. It turns out it's actually quite effective, in fact, more effective if people start relaxing social distancing measures. And this is what the two plots show. The left one shows slow relaxations of NPIs, and the right one shows fast relaxation of NPIs. And the numbers and differences tell you how much improvement you might get over no vaccination versus targeting older population and then targeting nodes with higher degree. Again, targeting here would mean you use a noisy way of targeting high degree nodes. It also works for high and low vaccine efficacy. Again, you get significant savings in terms of interventions. And this is kind of important, especially for resource poor countries where it's unlikely that Moderna and Pfizer vaccines are going to be available anytime soon. My understanding is the vaccines that are being considered for many places across the world have much lower level of efficacy. They are very useful and very important and effective, but not the same level of efficacy as the Pfizer and Moderna vaccines. So why do these strategies work? Um, as everybody knows, infection spreads and the risk here is not, when you give a vaccine, for instance, the person who gets the vaccine, of course, is protected to a large extent, but it also decreases the probability of onward transmission. So this balance between the exposure and infection risk and the disease risk, which is individual risk, is what is at play here. And what high degree node vaccination does, and it is quite clear, intuitively obvious, is that they really slow down the forward transmission. And this is done essentially recursively because one person doesn't infect the next set of his neighbors and they in turn don't affect next set of their neighbors. And this really reduces the overall uh, epidemic size and its growth rather dramatically. I have just one or two plots to show you the network structure and their changes. The paper has lots of details on this. Uh, but what it shows you is how the eigenvalues of the network and the maximal core of the network, the K core, which is basically a dense subgraph in the network, change as these vaccines are given. So this shows you to the left plot, the first eigenvalue, which is a good measure of how well the network is connected. And there's a very nice set of results in theory which show you the connection of the eigenvalues to the spread of the epidemic in network. Uh, of course, those things work for the bounds you get do not directly apply in our particular setting for various reasons that we can discuss later. But this shows you intuitively the lower the eigenvalue of the network, the slower the spread. And high degree based strategies show effectively reduce the eigenvalue very, very quickly is what this shows. Similarly, the size of the K core, which is a dense subgraph, which is another property that affects how fast the disease would spread or at least sustain itself, is also reduced very, very rapidly. So these are the structural properties of the network that change. They of course have impact on the dynamics, and the final outcome is really the complicated dance between the dynamics and the structure itself. And we have defined a new concept called vulnerability of a node that captures the structure and dynamics in a very, very interesting way. The paper has details about it, and that's how we would do the analysis. So let's go to the last part. How do we implement this, right? So our view is that digital contact tracing apps provide a very, very straightforward way to implement this in practice. And we'll come to the limitations too. So I completely understand the problems that might occur as well. But at least if the contact tracing apps are used by everyone or by a large fraction of the folks, then you can take the same apps and use the count of interactions to estimate degrees. I also know that these apps produce these pings every few minutes to preserve privacy. But in that case, you can use that as a measure of weighted degree, and that's why we studied both degree and weighted degree as our policy schemes. So next, we don't have to reveal the degree. You can actually get a sense for how high the degrees might be by doing sampling, and then the individual app on the person's phone can actually essentially tell the person or intimate the person that your degree seems to be high enough that you might want to consider taking vaccine. So none of the degree or the fact that they were moving around a lot has to be revealed to anybody. They can just report that they have gotten this notification and that they need the vaccination. Finally, you can actually improve this by taking into account age and other risk factors. We've also tried to correlate degree with various types of activities people do. And that is another way, if you don't have apps, to try and estimate degrees and provide vaccines. So there are multiple limitations. This is not all, it's not that there are no limitations, in fact, quite a few limitations. One is that the network is based on number of social theories and data. So there is clearly a possibility the network is off. We think the network is quite good. I would say better than any other representation that one has right now for US and Virginia. It captures a lot of data that has been measured about the social networks within the state. The second and possibly a very important limitation is that the natural infection has already infected some of the super spreaders. And so, maybe the vaccines are useless in that case. This possibly could be the case, but our results show that majority has not, if the majority of high degree nodes have not been infected, then this would work. Now, we haven't done a study which says, takes some percentage of these nodes, in fact, vaccinate them and don't vaccinate others, or make them already not individuals who can spread the disease. We do not have data about it. Later on, when such data is available, we can do a retrospective analysis. Third is the background interventions that are in place. We have done our best estimate based on what we understand is happening in the state in terms of mask usage, in terms of closure of facilities, in terms of what people are doing in terms of compliance to social distancing measures. But again, we cannot be quite certain exactly what the numbers are. The next limitation is that the vaccinated node, if it gets infected, we assume that it can transmit like any other node. This is again something that is being studied, and I think in the next month or so we'll have a much better sense of what the onward transmission probabilities are for a vaccinated node. And finally, the results depend on usage of these apps in a society and the compliance. And this, if not enough people are using this app, then of course the app-based strategy won't work. But as I said before, you can still get a surrogate of high degree by looking at the profession people follow, and that we have done in the past before. So medical workers of certain kind, or emergency workers of certain kind, or folks who work in shops of certain kind might all have high degree, as we have found out. So let me close the talk and then open the floor for discussions. First, we think that if you want to do real-time epidemic science, which has some impact in practice, then you have to work closely with stakeholders. The work we have done has been deeply guided by our stakeholders at the state and federal agencies. we feel that's really the only way to try and build systems that are realistic enough and try to capture the questions that are at hand. Second point we've learned is that you should be agile and flexible. For all the modeling work we've done for 20 years, and we thought that could be applied directly, we found the hard way that the situations are always that much different that things don't work out immediately. The agility is important. The results are needed in very short order, oftentimes for policy making, and this really produces an important challenge for science and policy making. You have to do good enough science in a short time to provide reasonable results. One might argue that it should take more time, but not providing reasonable answers is not providing an answer at all, and that has different weaknesses. We have found that team science is the only way to study this, and it's unusually effective. I mean, it's very hard to bring a team together, but when the team comes together in this form, it produces remarkable outcomes. The next point we've learned, and all of us are aware of this, is that social, political, and economic considerations are actually equally and probably even more important to control of pandemics, such as the ones we are seeing. I would argue that as a strategy, we all knew what we need to do. It's these considerations that have made controlling the pandemic hard. And the last part in lessons learned is that as much as it's important to get these scientific results, communicating them during a pandemic is non-trivial and has to be done with great thought and has to be very deliberate. Because people are really looking for results, people are trying to base their decisions sometimes, and if this is not done well, this has a lot of downstream problems that again we have seen during this pandemic. I want to quickly tell you all that working very closely with Devdutt, Sonia, and Francis at Chalmers and their students and postdocs, we have started building a digital twin for Sweden as well. I think we are quite close. In fact, I think a simple version is probably available in the next few weeks. I'll let Devdutt and Sonia and Francis say more about it. But I think that particular network, once built, can also be used to study questions such as these in Sweden, and we really hope that we can do it. They have taken great pains to collect data that is relevant to your context, census data, data from other sources, travel data. Sweden actually has a lot more data, it turns out, than US has in some ways, although sharing is then that much harder in Sweden than US right now. But I think they've done an amazing job in pulling this data together. We've been working closely for a year now, and we think that this can prove very useful. So with that, Devdutt, I'll stop. Thank you again very much for listening, and I'll take questions at this point.
Thanks a lot, Madhav, for a fantastic overview of the work of your team and immediate consequences in practice. And like as Frederick is showing, we all have our virtual clap in the Zoom room. So if you open up for questions, people can put it on the chat, or you're welcome to ask directly as well. I can start with a question here that's by Alexander. He says, what about, do your studies take into account the controls for, and I guess he means things like lockdowns of various severities that have been imposed. How do you account for that when you do your analysis?
Yeah, so Alexander, as I said, we have 4 different non-pharmaceutical interventions that we have studied. Their levels are not easy to estimate exactly. So we have done the best we can in terms, at least for our state, to try and pick those numbers up. And then we've done sensitivity analysis where numbers could be off by a certain value. But a very good question. And as I said, that is really important. That changes the network constantly in the process. And that's why I think theoretical results that people had studied and people have intuitively felt that, oh, high degree would always work, need not necessarily work when the network is constantly evolving.
Then there's a question from Sebastian. You want to go ahead and ask Sebastian?
Yes, thank you. So I have a question about regarding different forms of feedback loops. And that could be, for example, between like the vaccine prioritization and human behavior, because I don't know that, but I suppose that there could be a case that the different vaccine prioritization methods actually affect differently human behaviors and create some sort of like feedback loops. So for example, if you start vaccinating super spreaders, then that like, and people know that this is the priority of the vaccination, then I mean there's a chance that people actually become like more risk prone and take more risk, and that could also have an effect. And I suppose that's very difficult to represent in different like models. And yeah, I don't know how to what degree this actually occurs and so on.
Yeah, it's a very good question. So representation of behaviors and their adaptation is central to the story, right? We have done a few adaptations, such as when people might take a vaccine and start moving around a little bit more. Now, the particular adaptation you're saying is really interesting, which is if I feel that I'm going to get the vaccine, if I'm viewed as super spreader, then maybe I will move around a lot. And that's absolutely an important question to study. We had thought about it, and we felt that if the assignment is not done precisely, this is why I've taken this noisy representation where everybody in the top group doesn't get it, but they get it preferentially, then it potentially mitigates it to some extent. But I take your point. There is always a chance that the society will adapt and essentially promote bad behavior, quote unquote, if the strategy is used. I don't have a perfect answer for it, unfortunately, but very well taken point.
Then there's a question by Will. You want to go ahead, Will?
Hi, thanks very much. Really interesting talk. I guess I was curious about whether you've looked at vaccination of younger age groups. In some of the contact tracing data that we look at, you have quite high contacts in younger age groups compared to the older age groups. So you may have some, individual level characteristics that are more easily estimatable, more easily estimated than node degree, but they may be very good proxies for node degree. I guess I was interested in your comments on that.
Right, I think it's a very good question. So the system is set up that we could actually assign vaccines to folks who are younger. We just kept it where, at least in US, because the trials have not been done, they had certainly not, they decided not to provide vaccines to folks below a certain age. But I agree with you. I think younger kids, although they have been more and more asymptomatic and have not shown, bad effects of the disease, might be important in terms of spread. And one could estimate them much better because of the surroundings that they work in. And we're happy to undertake that study if there is interest in it.
Okay, so while we are waiting, maybe I can throw in one thing related to a question that was asked earlier. So in your one of your figures, you showed that the effect is even better if social distancing measures are relaxed more. If people start interacting more, the effect of the vaccine prioritization is better. Is that, I mean, how would you explain that? Is that some element of herd immunity, or?
No. When I say better, maybe I should clarify it. So I should go back to the slides 1 minute. Very good question, Dave. That let me go back to the slide there, because this is when NPIs are relaxed. This one, correct?
Right.
Yeah. So what we are trying to say here is the comparison. Of course, if the relaxation doesn't happen, you do get more things. So this notion of better is comparing the two strategies when relaxations are happening, right? So let's say the relaxation, you decide that people are going to relax social distancing norms in over a 5-month period. And then you compare no vaccine strategy to targeting old people strategy to targeting high degree strategy. Then we are comparing between those strategies. I'm not comparing in this the difference between no relaxation and relaxation. Mm-hmm. So maybe my use of words was one that causes misunderstanding. So the improvement is really between the strategies when all of them are under the same scenario.
Mm-hmm.
So that is reasonably well explained, because what is happening is when more and more people move around, the impact of vaccines in terms of essentially slowing down tertiary, infections actually is quite remarkable, as you saw in the decrease of the eigenvalues, Dave, and from that the sparsity of the graph. So that's why you get this kind of decrease.
So another question. Oh, sorry. Let me see. There's Laura. So Laura, go ahead.
Yes, I wrote the question on the chat as well. You what you call old age, you seem to use a criteria that's over 50 years old, and that doesn't seem to be that relevant for high risk for death. Did you try comparing your effects on death rates using over 70 or over 80?
Yes, actually we did try that, Laura. Good question. We did actually 65 and above, which is something US has considered, and we get very similar results in that case as well.
Okay.
So Madhav, if I can ask another question. So many of your results that you showed us have to do with what is the effect on the total infections. But what about mortality? Would that be, I mean, isn't it, for example, the mortality in COVID is much higher in the age group over 70 than under 70? And so if you take that into account, doesn't that argue more for vaccination based on age, prioritization by age?
So we, at least our results say that even for mortality, the degree-based heuristics are actually good, because they prevent the infection from even starting at that place. The disease model does account for age-based differences in terms of hospitalizations and deaths. So we have that representation. So at least one way to explain what's happening is that, let's say there is a cluster of old folks in a place, and Sweden had that, and US also had such situations. But perhaps by doing this, you don't let the disease even reach certain quarters at all. And that's how you would end up preventing it. But that's what the results suggest, that even when they have higher chance of getting hospitalized and dying, it turns out that because of the way the vaccines are done, you are essentially controlling the overall risk in the system itself. And that's what I was trying to say in one of the earlier slides, that it's a balance of individual risk versus the system risk.
That's interesting. So let's see, there's a Simon, what you want to ask?
Simon Levin, yes, Simon, yes. This is a question from my collaborator and my mentor in many ways in world of epidemiology. And Simon, thanks for asking. The question you have raised is about societal protection and individual protection. You're absolutely right. But we think that degree-based strategies actually protect even people who have higher risk in terms of more hospitalization and deaths. At least the results suggest that, Simon. Now, I'm not arguing that one doesn't protect folks in old age homes and such. That would be a wrong implication from this. But I think that after the first set of folks who are in such places have been protected, I think degree-based analysis should be considered, because it's likely to provide really broad societal value.
Yes, I just wanted to point out there, Madhav, a beautiful talk, that there may be situations where protecting the society as a whole might actually put some individuals at higher risk, and that's not so much a scientific decision as a societal priority decision that has to be made.
You're absolutely right. So, and that's why I think resource poor countries, I bring this up, so your point is absolutely spot on. We have very limited vaccines in resource poor countries, and it's their societal decision of whether they want to provide resilience for the entire society at large, or do this, protect individuals. So absolutely well taken point, Simon. I agree with you.
So there was in the media all around the world, people talk about the famous or infamous Swedish strategy, depending on who you are and what your sympathies are with. But so, I mean, one reading of the Swedish strategy is to protect the very vulnerable people, the old age group, and let there be a reasonable spread in the rest of society to develop herd immunity. That's one possible way of viewing it, but I'm not sure that's the official strategy, but this is one way you could think about it. So, I mean, your results have some implications for that.
This is more on vaccination. If you ask and this is a personal opinion, I think in a pandemic like this, the levels of herd immunity that one needs are fairly high. And in general, those strategies are unlikely to work, in my opinion. But of course, again, it's a societal decision, Devdutt, right? One has to balance, economic costs, people feeling really lonely. And Sweden looks like made a particular decision. Some other countries made a different decision. I think there was a middle ground, basically by even simple measures like mask wearing and keeping basic distance. Some countries have shown that you can control it quite well. So there is a balance that one can strike. But I think you ask an important question, but it's a question for every country to sort of decide how they want to let it play out.
I was wondering that there is an implication even for the vaccine prioritization strategy based on that, right? Because you could prioritize age groups because they are the most vulnerable, or you could do it as you said. I mean, your strategy is more to decrease the general level of infections. That protects also the old age group better, is your argument.
Yes, that's at least that simulation results suggest that's the case, that they will get good protection even when you don't vaccinate them directly because you get indirect protection.
So, right, that's a very interesting and non-trivial implication. So we've already gone over our time limit, but we'll wait for maybe if there are some other people who want to ask yeah, okay, so there's another hand from Laura, so she go ahead.
So it's another question. How much do the digital twins give you information on network and high people with many contacts? Are they at that sort of, do you have that sort of detail? If you don't use app contacts, do you have, what does the digital twin say?
Okay, so
about the network.
I'll try to interpret your question. I didn't completely follow it, but your question is, how does the digital twin of Virginia look like? Is that a correct interpretation?
Well, I mean, does it give any information on who has many contacts and who has few contacts?
Yes, exactly. Good question. So as I said, there are two ways to implement the strategy. I think digital app-based is a very good strategy if enough penetration of the app exists and people are willing to follow it. But we actually see interesting correlations between certain kinds of professions and high degrees, and the paper has that information again to some extent, and that could be used as a different way of targeting folks. And in that case, it's turning out that critical workers are indeed a good set. Folks who work in grocery stores, again, are a good set. They are quite intuitive in some ways. Folks who provide basic services where they are getting exposed to individuals seem to be the categories that have high degree, and it's completely intuitive in some ways, but the correlation comes out quite naturally from a network.
So, but you would get a much more coarse-grained information that way about who is a high degree versus
That's
if you
correct.
had very highly used social this contact app.
Mm-hmm.
The contact app, by the way, is completely non-existent in Sweden.
Right. So what is interesting, Devdutt and Laura, and maybe this is something that didn't come out well in the talk. All the analysis was done based on building this digital twin for the state of Virginia. Implementation of strategy does not require the social network at all. What it tells you is that, and my hope and assumption, I'm fairly confident that the Swedish network will be somewhat similar to Virginia. It will be different in some ways, but the basic structure will not be super different. Then what it says is, to implement this strategy, you don't need the network at all. You just need a way to estimate individuals' degrees and to let them know if they have high degrees.
Mm.
So this is the part that I personally find most exciting, because if you had to build a network for every country, figure it out, make sure it's right, then that's a different matter. What this is saying is that at least Western countries, which have similar structure, oftentimes in cities and rural areas, and travel times and distances, are likely to have very similar networks. And we see that actually. We had built a version for Sweden with Devdutt and his colleagues some time back. Not super different. There are important differences. There's no denial. And that differences would change the level of improvement one would get. But I think what certainly stands to reason is that you will get similar results for other countries. The levels might change some, and you don't need the representation at all to implement it.
Isn't there a high risk of discrimination and of missing some groups whose behavior is different from other groups by sort of taking over a model that you don't really have details, where you don't really have details on the population that you apply to?
So maybe I'm not suggesting I don't build one. I'm saying that if the goal is quickly to establish it, then my belief is that for, say, a place like Sweden, the structure of the network would have lots of similarities to Virginia network. Now that's an assumption, and I can't be 100% sure. So your point is absolutely correct. Ideally, one should make the network to make sure that the strategy works. But then to implement the strategy, in your case, you again don't need the network. You need the network to verify that this is indeed the case. You don't need the network to implement the strategy. That's all I was saying.
So talking of networks, if Sonia and Swapnil are still there, if you want to jump in and say something about your network for Sweden as it exists today, a status report, and whether it could be used for this kind of application as well, in addition to what you're using it for right now. Maybe they've left. I saw that they were there in the talk earlier. So
yeah, hi.
There's
Swapnil
Swapnil.
Yeah. So basically, we are creating like the mobility model for Sweden. Like basically, we have up to the precision of decimal zones. Basically, we are accurate up to decimal zones. Like these zones in Sweden are where population is around 1,500. And we also try to place them like precisely at the building level, because we have building data as well. And we are using something called as Chalmers data. So Chalmers is, if you know, it's like, it's like a mobility model created by Traffic Worket, which is like a government agency for transport in Sweden. So we have obtained some data from them to get an idea about about some mobility patterns throughout Sweden. Okay, so so basically, but our focus is mainly on mobility. We are still not sure how much it can be used for example, disease transmission things yet.
Okay,
so
thanks.
If
So
you have the data, then we are happy to, we're working on it. I know that. But we're happy to work with you all closely to try and, the disease models are not going to be that different within host and across host disease models. We can take what is known in the US, and at least as a way to start to answer Laura's question, the question of risking a strategy, this would be the first representation, and the network and the disease models can keep improving over time and give a better understanding. But the first cut could certainly be done for Sweden relatively quickly, I think.
Let's follow up on that later, but we have already gone way past our time, Madhav, and thanks a lot for giving us that time from your incredibly busy schedule, especially during these COVID times. And let's thank you again, and let's see if we can actually do something interesting together with this kind of with your approach.
Thank you
Thanks
again,
Madhav.
Devdutt, and everybody at Chalmers and my colleagues. I mean, I'm so delighted that Dick and Ravi and Simon and all my postdocs and others, staff members and Chen were able to attend. I could not be pleased enough. So thank you very much, Devdutt.
Thanks very much.
Honor.
Yeah, thanks.
Yeah, bye.
Bye.